Our topic is inflammatory bowel disease. Inflammatory bowel disease containing two main categories of inflammatory bowel disease. Environmental triggers like antibiotics, certain diets, smoking, stress, non-steroidal anti-inflammatory drugs, or infections. As we said, Crohn's disease, ulcerative colitis, and intermediate colitis. Crohn's disease characterized by stenosis, fistulae, deep abscesses, granuloma, and extracolonic involvement. Ulcerative colitis is characterized by bloody diarrhea, mucosal inflammation, continuous involvement, and intermediate colitis characterized by diarrhea, abdominal pain, relapsing course, anemia, and extra-intestinal manifestations. Crohn's disease, intermediate colitis, and ulcerative colitis share many common features, and misdiagnosis is possible. Distinguishing characteristics between ulcerative colitis and Crohn's disease. In ulcerative colitis, it is chronic mucosal inflammation, rectal and colonic involvement, involves the rectum and colon, symmetrical and interrupted continuous inflammation with rectal bleeding. In Crohn's disease, it is chronic transmural inflammation, not only mucosal inflammation. Involves any part of the alimentary tract, not only the colon and the rectum. Asymmetric and segmental distribution, not continuous distribution as in ulcerative colitis, with rectal sparing, granulomas, and fistulas, multiple fistulas. In ulcerative colitis, it is, as we said, it is a non-specific inflammatory bowel disease of unknown etiology that affect the mucosa of the colon and the rectum and present in both sexes. The incidence of ulcerative colitis between 2.2 to 14 per 100,000 population occurs in 3 peaks of age: early adulthood, between 40 and 60 years, and third after 70 years, but 1 to 2 per 100,000 population occurs in children. Risk of cancer is low during the first 10 years in ulcerative colitis, but then increased in a rate of 1 to 2 per year. The causes, it is autoimmune, contribution of autoimmune, genetic, infections, non-steroidal anti-inflammatory drugs, stresses or psychological factors. This may be causes or vicious circle may be causes of the ulcerative colitis, and genetic susceptibility is very important, and we found 5 to 10% of the affected persons have positive family history. Cigarette smoking found that nicotine can cause remission in ulcerative colitis, and also appendectomy have reduced number of relapses in ulcerative colitis. But cigarette smoking worsens Crohn's disease, but can cause remission in ulcerative colitis. Macroscopically, in ulcerative colitis, it is called pancolitis when the entire colon is involved, proctitis when the rectum is involved. Sometimes the terminal ileum is affected, and it is called backwash ileitis. The rectum is always involved. The disease is present in continuous fashion and shows confluence of numerous ulcers with areas of regenerating mucosa, and this is called pseudo polyps. This picture showing the continuous affection of the colon with ulcerative colitis with pseudo polyps. Microscopically, acute inflammatory cells infiltrating crypts of lubricant at the base of the mucosa to form crypt abscesses, and superficial desquamation of the overlying epithelium leads to ulcer formation. Clinically, bloody diarrhea, abdominal pain, and fever. This is the main symptoms. This present by pancolitis in 20% of the patients and mild colitis in the majority of the patients. And the mild colitis, more than 50% presented as bronchitis affecting the rectum and less than 50% affecting the left colon or left coli. Severity of the colitis is categorized as mild, severe, and very severe. Mild, the patient had less than 6 bowel motions per day. Severe, more than 6 bowel motions per day with abdominal pain, anemia, fever, weight loss, toxic megacolon, which is severe form with severe diarrhea, fever, and the clinical picture of proctitis, like urgency, tenesmus, frequency, blood, mucoid, and diarrhea, can be diagnosed by proctoscopy. Clinical picture of pancolitis, like anemia, inertia, anorexia, fatigue, and weight loss. Extra-intestinal manifestations. There is 4 extra-intestinal manifestations: dermatological, ocular, musculoskeletal, and hepatic. Dermatological extra-intestinal manifestation of ulcerative colitis. First one is erythema nodosum, which is a rash, tender, symmetrical raised erythematous papules on external surfaces of the arms and legs, and skin disease parallel to the activity, but not to the severity of the disease, and it is rare to precede the diagnosis of ulcerative colitis. This is a picture of erythema nodosum. The second skin sign of extra-intestinal manifestations of ulcerative colitis is bioderma gangrenosum. It starts as erythematous plaques or papules or blebs in the pre-tibial region and can progress to ulcerated, necrotizing, tender wound with ill-defined purple-red margin. This is another picture of bioderma gangrenosum, and show this is the ulcer formation. Ocular signs of extra-intestinal manifestations may be episcleritis or iritis and uveitis. This picture represents the upper one is diffuse episcleritis and the lower one's anterior uveitis. The musculoskeletal extra-intestinal manifestations may be acute synovitis or ankylosing spondylitis. About hepatobiliary extra-intestinal manifestations, the majority of hepatobiliary manifestations is fatty infiltration of the liver, and to minor extents it may lead to cirrhosis or sclerosing cholangitis. Sclerosing cholangitis is a chronic cholestatic syndrome characterized by fibrosing of the bile ducts. And 50% of sclerosing cholangitis patients have ulcerative colitis. There is a link between ulcerative colitis and sclerosing cholangitis, with increased risk of cholangiocarcinoma. This is the risk of cholangiocarcinoma in ulcerative colitis patients. It's about 30 folds that's the normal population. What about the diagnosis of ulcerative colitis? It's by history and laboratory workup and endoscopy and radiology. History of symptoms like diarrhea, urgency, tenesmus, systemic symptoms like fever, arthritis, skin manifestations, or weight loss. Lab workup like CBC, you may find leukocytosis, anemia, decreased hematocrit, increased platelets, or increased liver enzymes. Stool analysis for fecal leukocytes, and stool culture for other organisms, maybe due to gastrointestinal infections. One of the best markers of diagnosing and follow-up inflammatory bowel disease, what's called a calprotectin. Calprotectin is a neutrophil protein found in both plasma and stool. It's stable in feces for several days. It is used for differentiation between organic diarrhea and functional diarrhea, and serial monitoring of progression of the disease. Calprotectin. Other serological tests of the inflammatory bowel disease, what we call in PANCA, perinuclear anti-neutrophil cytoplasmic antibody, which is found in about specificity 94% and sensitivity 5-7% in cases of ulcerative colitis, or ASCA, anti-Saccharomyces cerevisiae antibodies, which are more present in Crohn's disease than ulcerative colitis. Third thing of diagnosis in endoscopy, either colonoscopy, sigmoidoscopy, or video capsule endoscopy. Colonoscopy, in cases of mild ulcerative colitis, we found granular texture, mucosal friability. In moderate cases, spontaneous hemorrhage. In severe cases, we found ulcerated mucosa with severe bleeding. We must take at least 18 biopsies should be taken, with 4 biopsies from the rectum for diagnosis of ulcerative colitis. This picture showing a case of ulcerative colitis. The left one is hyperemia with granular texture of the colon, and the right one with cooler button ulcers. Another pictures of colonoscopy pictures showing loss of haustrations in the left picture, and in the right picture mucosal friability and hyperemia. Another pictures of ulcerative colitis showing the continuous fashion hyperemia and pseudo polyposis, which is consistent of diagnosis of ulcerative colitis. Radiology in mild cases of ulcerative colitis we see speculations and cooler button ulcers. In chronic cases, we may see loss of haustrations, flat mucosa, narrowed caliber, and lead pipe colon. This is air contrast barium study and showing manifestations of ulcerative colitis. One of the major complications of ulcerative colitis is what we call toxic megacolon, which is a severe form of ulcerative colitis, and we found in X-ray a dilated colon more than 5.5 centimeters. This is a picture of toxic megacolon. We found very dilated colon more than 5.5 centimeters. Differential diagnosis of ulcerative colitis, we must put Crohn's disease, radiation colitis, ischemic colitis, infection like Salmonella, Shigella, Campylobacter, etc. Drug including non-steroidal anti-inflammatory, retinoic acid, gold, or contraceptive pills. This table represents the differentiating points between Crohn's disease and ulcerative colitis. In Crohn's disease, involvement of the terminal ileum in Crohn's disease, it is commonly, but in the ulcerative colitis, it is disease of the colon and rectum, so it's seldom involved in the terminal ileum. In the colon, it is the ulcerative colitis always involving the colon or the rectum. Involves the rectum, it is also the ulcerative colitis, which is usually involved in the rectum. But the perianal involvement is commonly involved in Crohn's disease more than the ulcerative colitis. In the bile duct involvement, ulcerative colitis commonly had a higher rate of primary sclerosing cholangitis. Distribution of the disease, ulcerative colitis is a continuous areas of inflammation in the colon, but Crohn's disease has a patchy areas of inflammation. In endoscopy, in ulcerative colitis, it's continuous ulcers, but in the Crohn's disease, it is linear and snake-like ulcers. In depth of the inflammation in the ulcerative colitis, it is a shallow and mucosal disease, but in the Crohn's disease, it is transmural deep into the tissue. Crohn's disease is characterized more than ulcerative colitis by forming fistulas and abnormal passageways between the organs. And Crohn's disease characterized also by granulomatosis. Surgical cure, usually ulcerative colitis cured by removal of the colon, but in the Crohn's disease returns following removal of the affected parts. Smoking may lower a risk of the disease in ulcerative colitis, but worsen the disease in Crohn's disease. Cancer risk, it is higher with ulcerative colitis than the Crohn's disease. This is a picture of Crohn's disease with skip lesions, multiple separate sharply delineated areas of the disease. There is areas of the disease and areas of skip lesions, not continuous lesions like the ulcerative colitis. Another picture of Crohn's disease, which show a diseased tissue is depressed below the level of normal mucosa, giving the picture of cobblestone appearance. This is different from the pseudopolyps in the ulcerative colitis. So in the ulcerative colitis, there is a picture of pseudopolyps, but in the Crohn's disease, it is a picture of cobblestone appearance. Treatments of inflammatory bowel disease or ulcerative colitis Crohn's disease may include dietary changes, lifestyle changes, drug therapy, and surgery. And treatment goals of inflammatory bowel disease, we must reach a rapid induction of remission and maintenance of this remission and weaning of corticosteroids if used, with mucosal healing, fewer surgeries and hospitalization, better quality of life, and effective treatment of extraintestinal manifestations. This is the goals we must reach in treatment of inflammatory bowel disease. So management include medical and surgical, and medical include many lines of medical treatment. First line is aminosalicylic acid, second steroids, third immunomodulators, and fourth is biologic agents. start with medical treatments. We start, as I told you, first by aminosalicylic acid, steroids, immunomodulators, and biologic agents. Aminosalicylic acid drugs, as sulfasalazine first drug discovered, there's a newer groups like ordintaza, asacol, sanazovirine. These work locally on the lining of the gut to reduce inflammation. An example is sanazovirine. It is 5-aminosalicylic acid joined to a sulfur group, and to be activated, the sulfur group must be removed. The sulfur group removed in the large intestine, and also the sulfur group has an anti-inflammatory effect on the joint. Another example is the pentasa. It is pure 5-aminosalicylic acid molecules in micropellets, breaks up in the stomach, and slowly dissolves as it travels through the intestine and the colon. Efficacy of aminosalicylic acids, up to 40% of patients go to the remission with the usage of aminosalicylic acids. Possibly 1 to 2 less acute relapses per year in the maintenance, and average relapses per year is 3 to 4. Real benefits of aminosalicylic acids: reduce the risk of bowel cancer on long-term follow-up. The second line, we may use steroids used to control symptoms, not to maintain long-term remissions. Has an immunologic and anti-inflammatory effects through cytokine cascade, prostaglandin production, and leukocyte reaction, and used only for moderate to severe cases of ulcerative colitis and or cases of failed aminosalicylic acid treatment to induce remission. Dosage in severe cases: prednisone 40 to 60 mg per day. Recent drugs as budesonide, less side effects and with great potency to glucocorticoid receptors. Steroid effectiveness: highly effective for induction of remission, but not very effective in maintenance of remission. Short-term response rates from 12 to 6 weeks range from 70 to 90%, not effective in maintenance of remission. But steroids has many side effects like depression, anxiety, buffalo hump, bruising, bone thinning, muscle weakness, obesity, acne, and etc. The side effects of steroids. During usage of steroids, we are confronted with some different situations, like corticosteroid refractory patients. These patients who have active disease despite prednisone up to certain level over a certain period of 4 weeks. This is a refractory disease, not respond to corticosteroids maximally. And corticosteroid dependent disease. Patients who are either unable to reduce corticosteroid below a certain doses, or who have relapses within 3 months of stopping corticosteroids. We have the aim should be to withdraw corticosteroids completely, but if we confronted with these cases, it may be difficult to withdraw corticosteroids completely. The third drugs in medical treatment is the immunosuppressants like azathioprine, 6-mercaptopurine, methotrexate, cyclosporin. This is interfere with inflammatory pathway. Up to 75% of patients brought into remission and needs close monitoring for toxicity. Also, a cyclosporin therapy may be used to induce remission in cases of refractory colitis. There is a question. We can use antibiotics in cases of ulcerative colitis or Crohn's disease. Usually, we not need antibiotics except for treatment of complications such abscesses or skin infection or in cases of toxic megacolon. We can use metronidazole, ciprofloxacin, or other antibiotics. But usually, if the case is not complicated by abscesses or skin lesions or toxic megacolon, we don't use antibiotics in treatment of inflammatory bowel disease. The fourth type of medical treatment is the biologic agents like anti-tumor necrosis factors, anti-interleukin 2-4, anti-CD3, or growth factors. The most famous one is the anti-nuclear factor infliximab or Remicade. It inhibits production of interferon, interleukin 2, interleukin 12 of benefit in 88% of steroid refractory patients or in severe colitis, given in 5 milligram per kilogram intravenously at 0 to 6 weeks. With another biologic agents as growth factors and visiluzumab. Remicade is the most famous one, but we must, this is the side effects of Remicade, may induce hypersensitivity, may induce autoimmune syndrome, may lead to profound immune suppression, and opportunistic infection can occur, and tuberculosis high risk. This is the side effects of and safety of infliximab or Remicade. But in cases of refractory cases, we must use these biologic agents. So summary of starting therapy, medical therapy of ulcerative colitis, steroids. It is established in induction of remission established in 70 to 90% of cases, but ineffective in maintenance of remission. And aminosalicylic acid can use in induction of remission and conflicting evidence in maintenance of remission, but it's important to decrease the carcinogenic transformation of the disease. Antibiotics has no role. Immunosuppressants established the induction of remission and established the maintenance. In biologic agent, it is important in establishing induction of remission and maintenance of remission, especially in resistant and refractory cases and severe cases of ulcerative colitis or inflammatory bowel disease. This is an important slide. We start medication, step up or top down evidence for disease modification. In clinical practice, a step up approach of adding therapies if first line or less toxic approaches are unsuccessful within an appropriate period is commonly used. We start by first line, second line, third line, fourth line. However, decisive treatment with a potent agent, what we call top-down approach, at any early stage may be preferred by the patient suffering measurable symptoms from active disease. Smoking cigarettes in ulcerative colitis leads to less relapses. But smokers in Crohn's disease have more relapses, disease more difficult to treat. Stopping smoking reported to have same effect on Crohn's disease as giving steroids. So it is give less relapses in ulcerative colitis, but worsen the disease in Crohn's disease. In patients of Crohn's disease and ulcerative colitis, we need the patients malnourished patients. So up to 75% of hospitalized Crohn's disease patients are malnourished. Why? Due to reduced absorption, increased nutrient losses, increased metabolic requirements, reduced intake, and lesions. What about the medication? As sulfasalazine reduces folate malabsorption, corticosteroids suppress small intestinal calcium absorption and increase urinary calcium excretion, Cholestyramine produce fat, calcium, and fat-soluble vitamin deficiencies. Sulfasalazine or metronidazole may cause nausea, vomiting, and dyspepsia, curdling the nutrient intake. So, malnutrition, we found cases, the inflammatory bowel disease case as malnutrition. And we found in Crohn's disease, the malnutrition is severer than in cases of ulcerative colitis. How to treat the cases of malnutrition or categories of nutritional therapy in Crohn's disease? I explained as total parenteral nutrition or enteral nutrition, alteration of gut flora by prebiotics and probiotics, enterocyte nutrition, presence of growth factors or anti-inflammatory omega-3 fatty acids. This picture showing the effectiveness of prebiotics and probiotics. It may regulate local and systemic immune function, metabolic pathway on nutrients, glycemic control, and cholesterol and amino acids, support the mucosal barrier, enhance nutrient utilization, prevent neoplastic changes, regulate bowel motility, regulate appetite, regulate inflammation, and prevent infections, systemic and gastrointestinal. For the benefits of probiotics in inflammatory bowel disease, may increase mucin production, inhibit epithelial interleukin-8 production by tumor necrosis factor alpha, maintain tight junction and epithelial integrity, and diminish visceral hypersensitivity in animal models. We can use the effects of omega-3 fatty acids on factors involved in the pathophysiology of inflammation. So omega-3 fatty acids may decrease arachidonic acid, decrease thromboxane, decrease leukotriene, decrease fibrinogen, decrease platelet activating factors, decreased platelet-derived growth factor, decreased oxygen-free radicals, and extra. So the omega-3 fatty acids decrease the factors of inflammation involved in the disease. So recommendations, possible nutraceuticals, our nutrition, medical nutrition to consider, to give prebiotics and probiotics, fish oils, omega-3 fatty acids, calcium, and vitamin D. On diets, we call probiotics, our Mediterranean diet rich in green leafy vegetables, whole grains, high in fish, olive oil as essential fatty acid. How to treat practically in cases of ulcerative colitis? We give rectal instillation of amino-salicylic acid or hydrocortisone. Or nicotine may improve symptoms in approximately 40% of the patient in cases of ulcerative colitis. Treatment of non-ulcerative colitis, we give usually we start by prednisone or anti-metabolites, and treatment of severe ulcerative colitis, it must be hospitalized. We give intravenous hydrocortisone and correction of electrolytes and malnutrition. What is the prognostic factors in severe ulcerative colitis? There is several prognostic factors. This slide shows several prognostic factors in severe gastroenteritis as altered consciousness, pulse, fever, spinal sounds, albumin, calcium, chlorides, potassium, bicarb, pH, and C, reactive protein, and bowel motions. The most severe form of ulcerative colitis is the toxic megacole, which may lead to shock of the patient and lead to die. This is a toxic fulminant colitis due to deep transmural dissection of ulcerating inflammatory process, generalized paralysis of the bowel wall with systemic toxicity. Diagnosis, as we mentioned, by plain X-ray, and we found dilated colon more than 5.5 centimeter, with decreased bowel sounds, painful, distended, tender abdomen, with systemic fever, tachycardia, leukocytosis, and shock. Treatment of toxic megacolon is NPO, nasogastric or intermittent suction, discontinue antidiarrheal drugs, intravenous frequent electrolytes and transfuse as necessary, intravenous hydrocorticosteroids, triple therapy by metronidazole, gentamicin, and clindamycin, antibiotics, rotate the patient to prone position every few hours to redistribute colonic gas, frequent abdominal examination with care. Surgical treatment, the last sort of the surgical treatment. Surgical treatment, we need surgical treatment, either emergency or elective. In cases or indication of surgical treatment, either severe bleeding, perforation, malignancy, severe infections, or failed medical treatment, we can resort to surgical treatment. And thank you.